We have discussed the hair follicle disorders, that is androgenic alopecia, alopecia areata, trichotillomania, telogen effluvium, tinea capitis, but this is hair shaft disorder. अगर आपके scores improve कर गए, so then you know your treatment is going to work and you can give the patient a little more confidence. Trichoscopy is basically a method of using the dermatoscope or a trichoscope in our clinic to diagnose the problems of hair fall instantly without going towards biopsy and without going for the special blood testing and the other labs. It basically bridges the gap between your clinical judgment and the invasive testing. You'll be able to identify the role and existence of trichoscopy in general, and obviously identify different hair disorders in particular and differentiate them from one. Assalamu alaikum everyone, this is Dr. Aisha Ghias and today the talk is going to be about trichoscopy because till now we discussed everything related to the skin problems being diagnosed using dermoscopy, but we didn't talk about hair disorders that can be confidently diagnosed if we use trichoscopy routinely in our practice. So today we are going to talk about trichoscopy, its significance in a dermatological clinic. So let's begin the talk. Because every day in our clinic, we come across such patients who are having diffuse kind of alopecia where nothing is very specifically, pointing towards diagnosis. For example, there is no single patch of alopecia. The patient is talking or complaining about a diffuse kind of hair loss, and you're in a fix if it is a telogen kind of hair loss or if it's a nutritional deficiency disorder leading to the diffuse hair fall, or if it's a female pattern hair loss or a male pattern hair loss. So if you use this trichoscopy in your clinic, you just put your scope on and instantly you know which kind of alopecia are you dealing with. So having said that, let's go to the presentation straight away and start talking about alopecias. All right, so this presentation was basically delivered at Islamabad at an HRSP event in Serena. Where there were so many dermatologists as well as plastic surgeons, and the talk was very successful. In fact, there many of my colleagues asked me and requested me to record this presentation once again and put it on YouTube so that it could be accessible to everyone for use. This is my department, Dermatology Department, Unit 2 at King Edward Medical University, and I owe all my successes to one of my mentors, Professor Shahbaz Aman there, who is always motivating me to go further and further related to these academic achievements. Okay, so these are my mentors. I always acknowledge them at the start of my presentations. Mentors like Iris Zilautic, Ashfaq Emargo, Emilios Lalas, Gipi Arkenziano, and of course Professor Shahbaz Aman and Professor Tahir Jameel Ahmed. So why trichoscopy? So trichoscopy is basically a method of using the dermatoscope or a trichoscope in our clinic to diagnose the problems of hair fall instantly without going towards biopsy and without going for the special blood testing and the other labs. It basically bridges the gap between your clinical judgment and the invasive testing. So you can always bridge that gap where you feel you're deficient in your clinic just by putting the scope on, and there you go. For example, there are 1,000+ causes of hair loss when you come across a patient in your clinic. Some of them belong to medical problems, metabolic disorders. They could be infectious diseases, psychiatric problems, and other hair-specific disorders. But then you don't know how to start with. I mean, you can take a long history, you can examine the scalp, you can also order blood testing. But if you do not do trichoscopy in a patient of hair fall, trust me, you are at a loss. So in all those causes of hair loss, if you want to put yourself at ease regarding the diagnosis, you can just put your scope on and diagnose the hair problems instantly. The term was basically coined in 2006. It started with this paper, and then it went on and on. And then there were so many inventions and so many discoveries related to trichoscopy. There are so many soft, the applications And the softwares that are in use related to trichoscopy, related to the reporting of the hair disorders, where you just put the picture that you take with the use of trichoscope into that software, and then it comes up with a proper reporting system, that is the caliber of the hair, the number of the hair, and we'll just touch that thing shortly. So the significance of trichoscopy is not only the clinical dermatopathological correlation, which I always mention in my talks. It's diagnostic. Obviously, you can monitor a problem, a disease, with the help of trichoscopy at various intervals during your treatment. And obviously, it's a resource saving technique. The specific learning objectives of today's presentation would be that you will be able to identify the role and existence of trichoscopy in general, and obviously identify different hair disorders in particular and differentiate them from one another. Okay, so let's see the normal hair. When you see the normal hair with the help of trichoscope, you see these hair follicle units. Not always the single hair is coming out of the follicle unit. And as dermatologists, we all know that there may be 2 to 3 hair coming from the same orifice, from the same hair follicle unit. That's why they are called follicular unit. Unit is one, but there may be many hair coming out of it. Like as you can see in this picture, all the hair are of similar caliber. They are all of similar thickness, but there is obviously a particular distance between the hair follicular units, and you are unable to see any empty follicles over here. So this is the picture of normal hair that you can see with your trichoscopy, and you can obviously report that thing with the help of your pen and paper. You can report it in black and white, that what is the count of hair that you saw in this particular window. There is always a calibration in that trichoscope, and whenever you're capturing a picture, there is a calibration over there, so you particularly know how much area have you captured in that photo. For example, a 2 millimeter area or a 3 millimeter area belongs to the problem in question which you are talking about. And usually we talk about 1 centimeter square area whenever we talk in terms of hair count and the number of hair follicles. It's the 1 centimeter square area that is being studied with the help of trichoscopy, and its difference is very important. If you do research on different hair follicle disorders and you use this trichoscopy in that research, you are referring to that area that you studied with the help of trichoscope. Obviously, you're going to monitor the disease. If you are, interventioning with some sort of drug and you're actually witnessing its results onto that hair fall problem, or for that matter, you are just following up the patient, you will be referring again and again back to that 1 centimeter square area at that specific point on the scalp that you used in the first place. So you can not only talk about the count of hair, their thickness, hair per unit, per follicle unit. You can talk about the skin in general. For example, as you can see in between the hair follicular units, the skin is pretty much normal. It's light yellow colors. There is no scaling, no pigmentation, no blood vessels visible. So you can report that thing up. And obviously, you talk in terms of blood vessels. So these things are very important. For example, a resident comes to me and I ask him, or I assign him the duty of trichoscopy of a particular patient, and I ask him to write down a report. Usually, the residents are in a fix where to start from, what to write in that report, how to end that report, what should be the components of that trichoscopy report. And these things are the ones that usually demand a little bit of concern and a little bit of time of consultant to make them understand that particularly. And I'll touch it in a minute, that what exactly needs to be written in a trichoscopy report. So we usually do not know the stats of hair in our population. We are usually referring to the stats that are given in the international studies. So for the matter of ease, I must tell you that the number of hair might be different in different areas of the scalp. For example, vertex, frontal, temporal, parietal, occipital. If the number of the hair follicle units is low, it would be about 120 per centimeter square. And if it is average, it would be around 160. And the higher number, which usually is a very, healthy scalp, will contain about 200 follicular units per square centimeter. And in 0.053, this is the thickness, mean thickness of the hair. that your scalp is having, and 0.050 millimeter is the thickness of the hair on in the occipital area, and 0.053 millimeter is the thickness of hair on the vertex. So these stats have been derived from international studies, and we are working on it at our level in our population so that we can come up with our own stats. Face washes, when I'm talking about face washes, it really is a serious matter. So the major differences between the soap and face washes, let me summarize for you. Now, moving forward towards the debate for cleanser versus face wash, you need to know the skin types. Once you know the skin types, you can choose the face washes better suited for those skin types. So which equipment do you really need to go for trichoscopy? The traditional, the ordinary, the usual dermatoscope that you're having with you can work like a trichoscope. You just have to put it on scalp and see for hair in particular. So what do you see? Basically, whenever you put your trichoscope on the scalp, you should have four things in mind. What are you looking for? Number one, you're looking for the hair in general and all the parameters of hair in particular. For example, the number of hair follicular unit, and the thickness of the hair, the texture of the hair, if it's broken or if it's having special diagnostic features like maybe exclamation mark hair or a flame hair, or for that matter, the other things which we will shortly talk about. You're obviously going to look for blood vessels. This is something which is very important, and usually residents tend to forget about it. So the blood vessels are very important whenever you're writing down a trichoscopy report or you're looking for some diagnosis in the hair disorders. You have to particularly pay your attention towards the presence or absence of any blood vessels in your field. All right. The skin. This is the right lower corner picture. The skin in general, if there is a scaling on the skin, या skin का color खराब है, or if there is any other disorder that you can look for over there. And the right left corner, the follicular dots. It may be of different colors, yellow dots, white dots. Okay. So the dots are very important. The empty follicular units also give you false appearance of yellow dots over there. So they may signify many types of hair disorders, which we'll talk about. So the dots are very much important. Follicular dots in your field of vision while you are doing trichoscopy. So these four things are very important. Keep them in mind, and you are going to write a perfect report on trichoscopy. All right. With the help of trichoscopy, you do not only identify the hair follicle disorders, that means the disorders of hair fall that we usually see, but you can also identify certain hair shaft disorders. Today's presentation is about different types of alopecia, so we will be particularly talking about hair shaft disorder, hair follicle disorders, but not the hair shaft disorders. Okay, so having said all these things about trichoscopy, its significance, how are you going down to write down the report of trichoscopy? What are you actually looking for when you put your scope on? Now let's straight away jump into the different kinds of alopecias and their diagnostic points on trichoscopy. Okay. So starting with the commonest type of alopecia that we come across in our practice, which is an androgenic sort of alopecia. What are the diagnostic features on trichoscopy? So as you have gone through the text in androgenic alopecia or a male pattern hair loss, there obviously is miniaturization of the hair follicle and the conversion of the terminal hair to the vellus hair. This is the pathogenesis of androgenic hair fall, and this is the miniaturized hair that you see on the trichoscopy. Well, on the left-hand side, as you can see the trichoscopy of the androgenic hair loss, androgenic alopecia. And if you clearly see, if you see with a little bit of more focus, you can see that there is different caliber of different hair follicles. Some of them have gone through the miniaturization process and they are kind of very thin, while others are of middle caliber, and some of them are quite thick. So there are different calibers in this trichoscopic picture. And as I must mention over here that the hair growth and the miniaturization, they are running in parallel. They are not synchronized. Hair growth is running at its own pace in a scalp, and hair fall or miniaturization process is running at its own pace. So you get to see all types of hair calibers in a trichoscopic picture of androgenic alopecia. I have symbolized this with the picture of the trees in the on the mountainside. You can see different caliber of trees, the thinner ones, the middle thickness, and the thicker ones. So this is just to make you memorize the picture so that whenever in clinical practice you forget the androgenic alopecia trichoscopic changes or the trichoscopic markers, you just think about this picture of the trees. And there you go. There you know that the different caliber of hair was the main thing. This is called heterogeneity of the hair thickness. So heterogeneity in the hair thickness is the diagnostic marker on trichoscopy for androgenic alopecia. All right, so hair shaft heterogeneity in androgenic alopecia, as I just talked about it. And I also have told you about human hair growth and hair miniaturization since they are not coordinated. So you get to see thin and intermediate thickness and the thicker hair all at one place. I have made this picture, this diagrammatic picture for you guys to understand that normally there are 2 to 3 hair coming out from the same hair follicle. And in androgenic alopecia, you get to see maybe single hair or 2 hair coming out from the follicles. If you want me to refer back to the picture of androgenic alopecia on trichoscopy, I can always refer back. As you can see over here, there is the 2 hair coming out from the same follicle. One of them is a miniaturized one and another one is a thinner one. Not miniaturized, but quite thin. Over here, you get to see normal caliber hair, 2 hair coming out from the same follicle. And over here also 1 hair follicle, 1 hair per follicle, 1 hair per follicle, 1 hair per follicle, 1 hair per follicle. So in androgenic alopecia, the number of the hair per follicle unit decreases. And there is also one diagnostic marker I must talk about. In androgenic alopecia, you get to see a couple of hair coming out from the same follicle unit. One in that couple is a miniaturized hair and the other one is of intermediate thickness. This is one diagnostic point in androgenic alopecia trichoscopy. So coming back to the diagrammatic picture, this is also just to make you memorize. All right, another trichoscopic picture of androgenic alopecia, you see that the number of the hair have reduced. The number of the hair per follicular unit have also reduced. 1 or 2 hair at the most are coming from the follicular unit. And the thickness varies. There is heterogeneity in the thickness of the hair shaft. And this is diagnostic for androgenic alopecia. The naked eye presentation, as you may see on the left side of 2 lesions, appears almost the same clinically. But when you go for the dermoscopy on the right side, as you can see in the upper lesion, you may see the pigmented network. And the network is kind of the regular one dispersed throughout the lesion. However, in the lesion lower below, in the lower picture on the right side, you may see these isolated dots and clots in the periphery of the lesion. All right. So when you're giving some treatment and you are, you want to see the response of that treatment on the hair growth, in terms of hair growth in androgenic alopecia, the increase in the number of hair per follicular unit is one of the first signs to see in female androgenic alopecia once you're giving some treatment. This is a positive predictive factor with any sort of treatment. For example, over here, units with 1 hair are almost 50% in a field of vision or in a field of view. But once you follow the patient after the treatment, maybe after 3 to 4 months, units with 1 hair are 0%. There is no hair follicular unit from which 1 hair is coming out, but there are minimum 2. So we can say that this has got a positive predictive value, and that means the increase in the number of hair per follicular unit. Follicular units are the same, 4 on left side, 4 on right side, but the number of hair have increased. So this is a positive predictive factor. All right, coming on to the second disease. This is alopecia areata, a patch of hair loss. Clinically, we can diagnose it instantly इसमें कोई हाई-फाई साइंस नहीं है, कोई confusion नहीं है. But once alopecia areata is diffuse, sort of, it does not have a patchy hair loss, then the problem begins. Then you have to really think about it. So I want you to see this exclamation mark blinking right in front of your eyes. This exclamation mark is diagnostic feature of alopecia areata on trichoscopy, and we'll shortly see how does it look like on trichoscopy. So this was one of my patients who presented to me with this diffuse kind of hair loss on the frontal scalp. So when the differentials, clinical differentials were like, it might be telogen, it might be trichotillomania, or it could be some metabolic disorder, or it could be alopecia areata. But then once I did this trichoscopy, as you can see, there are exclamation mark here. Now, what is an exclamation mark here? Referring back to our beautiful exclamation mark, the thickness is more on the distal end, while the thickness is getting reduced once you get proximal to the scalp. Somewhere near the scalp, you get to see nothing, and it seems as if there is a gap in the length of the hair. And then there is a little bit of hair follicle dot which is visible just above the scalp. So this is the exclamation mark, and these details are pretty much visible over here on trichoscopy. As for example, look at this here. The distal part is thicker, the proximal part is thinner, and somewhere near the scalp, the hair almost disappears. These hair are small, and these might be regrowing hairs, or these might be the miniaturized hair as a result of autoimmune process and the decrease in the caliber of the hair. Because this is an autoimmune disease, alopecia areata, and the inflammation is attacking right at the hair follicle. Another exclamation mark here, over here. I don't know if my cursor is visible to you. Okay, now it's visible. So this is the another exclamation mark here. One more exclamation mark here, another exclamation mark here. So these are all the exclamation mark here, and they are diagnostic for alopecia areata. Once you put your scope there, you know you're dealing with alopecia areata. Now your treatment is going to be quite customized and specific, and you probably are going to offer her intralesional injections of triamcinolone, which otherwise you would not dare to. All right. The same patient, after third injection of triamcinolone, and you can see that the hair growth is markedly improved. She's having, a good hair volume over here now on the frontal scalp, and the plan obviously is to continue with intralesionals. Okay, so trichoscopy for alopecia areata, as I told you, is exclamation mark here. The black dots where the hair have actually fallen off from the scalp, leaving behind this black dot where the residual hair is stuck in the scalp in the place where there was original hair follicle, and you get to see just the black dot while looking on the scalp from top. And then some of the hair might not be visible totally in your field of vision, and you see the thicker hair distally and the thinner hair proximally. These are called tapered hair. They are not called exclamation mark hair. You can only label a hair as exclamation mark hair if it is visible completely in your field of vision. If it's not, you call it a tapered hair. And then Paul Pinkus constrictions. Paul Pinkus constrictions are the constrictions visible in the middle of the hair shaft in alopecia areata, where some improvement has taken place. Probably you have given some treatment, or naturally, as a natural course of the disease, patient is on improvement and the hair has started growing in caliber. So you get to see the thicker caliber near the scalp, thinner in the middle, and then again the thicker caliber distally. These are the Paul Pinkus constrictions. So all of these features are diagnostic for alopecia areata. Numerous black dots in trichoscopic field are almost diagnostic for alopecia areata. So another confident thing that I have given to you today is that numerous black dots in trichoscopic field are almost diagnostic. I'm reading it again and again just to emphasize it. See this picture. This was a case of alopecia areata where you get to see all these black dots. These black dots are the residual hair that are left in the hair follicles after the distal hair has fallen off. And as you can see, the hair follicle still contains the root of the hair stuck in here, but from top it is already broken off. And with the help of trichoscopy, you see just the black dot, as you can see over here as well. So all the features of alopecia areata summed up in this picture. 4 pictures actually. On the top left side, you can see these yellow dots and the empty follicles. Okay, right upper end, you see the miniaturized hair, the small caliber hair. They are of similar thickness. They are all thin and they are all under the process of being attacked by autoimmune disease, the inflammation. The constriction of the hair just close to the scalp on the lower right side, and there is a black dot left where the hair has fallen off. This is the constricted hair, and we'll call it a tapered hair because whole of the hair is not visible in our field of vision. So this is the then complete hair we can see. So we'll call it a tapered hair. And over here, the black dots that are the broken hair from the scalp. And in between, you can see all these vellus hair that are left behind. Probably they are also going to fall off in some time. So these are the different features of alopecia areata that you can see on trichoscopy. Not always you get to see the similar trichoscopic picture, but since the diagnostic features are so many, since the disease is sort of dynamic, you may catch the patient at any stage. You may catch the patient at earlier stage where the autoimmune destruction has just begun. You may take the pictures at the where the disease is at a plateau already, where the major destruction has already taken place. So all the features of alopecia areata could be visible in that picture. Or you may capture the picture at a stage where the autoimmune destruction has probably at its minimum, or some treatment has been started and the patient is on improvement, or the disease has gone into remission. So there are different diagnostic features. There are different trichoscopic diagnostic points that you get to see in a picture. So you should not always fix up your mind that alopecia areata would be like this, alopecia areata would be like this. So I have shown you all the variations in the trichoscopy of alopecia areata. If you have the history and the clinical disease in favor of alopecia areata, and you get to see these yellow dots, which are empty hair follicles, obviously the diagnosis will be strengthened. Similarly, if you get to see this trichoscopic picture and clinically all the history and the clinical picture goes in favor of alopecia areata, so you label it as alopecia areata. Not always the trichoscopic pictures can alone be confidently made a basis of diagnosis. You always have to relate them to clinical pictures, clinically to the patient and also to the history. That's why we call clinico-dermoscopico-pathological correlation. Sometimes we really order biopsies after trichoscopic. Sometimes we can avoid the need of biopsies. So this is clinico-dermoscopico-pathological correlation, CDPC. And this is not you cannot, diagnose a hair follicle disorder just based on trichoscopic picture always. What's a pattern and what is a clue? So pattern is a structure that you see in more than 20% of that field which you are seeing with the dermoscope or the field of the dermoscope. So more than 20%, if you see something, it's a pattern. And if less than 20% is a clue. Yes, pattern and clue. So pattern is more than 20% and clue is less than 20%. Okay. So as for example, in the left hand side, you see that the pigment network is present in more than 20% of the lesional of the surface area that you are seeing with the dermoscope, and we call it a pattern. So there's a pattern of pigment network. However, on the right hand side, if you see this clod, is it a pattern or a clue? It's a clue. Okay, so there is also a scoring system that has been devised based on trichoscopy of alopecia areata. And it takes into account all the parameters that we just talked about. For example, the exclamation mark here, tapered hair, black dot, and the broken hair. And all these parameters are given -1 mark. While the positive thing, like the upright regrowing hair that might be visible in a trichoscopic picture and the pigtail hair are given +1 marks. Now, what are the pigtail hairs and what are the upright regrowing hairs? This is your homework. Whenever I'm presenting some talk, I usually leave some empty spaces. I usually, leave you with some mind evoking or provoking questions and some things to do at home, some homework like things, because I always believe that spoon feeding cannot always help in learning process. So whenever I'm taking class of undergrad students or postgrad students, I always leave them with some questions. I cannot spoon feed everything. So it would be a good idea if you read about upright regrowing hair, their features on trichoscopy, and also the pigtail hairs, and you write the answers in the comments section down below, and let me know if you're thinking on the right track or not. It would be really good, and I'll feel positive about it if any one of you listening to my talks about it, the pigtail hair and the upright regrowing hair. Okay, so we were talking about the predictive score. So you score the alopecia areata trichoscopic picture based on these parameters. You give -1 to all these features and +1 to all these, and then the final score is calculated. Once you have calculated the score at the start where the patient presented to you, then you follow up your patient after a couple of months. You've started the treatment. It's really very easy to score the patient based on this scoring system once again. And then it's an objective way of documenting the treatment response. And obviously, we scientists are running behind the objectiveness of our responses, clinical responses. This is the only thing that we can base our research on. So before treatment has no predictive value for regrowth. And once you calculate the scores after 2 months of treatment, you can predict this treatment is going to work or this treatment is not going to work for that patient. All right. So alopecia areata predictive scores after 2 months of treatment. इसमें आपने यही वाली स्कोरिंग सिस्टम के साथ उसको रिकॉर्ड कर लिया, और अगर आपके स्कोर्स इंप्रूव कर गए तो then you know your treatment is going to work, and you can give the patient a little more confidence that, see, this was your score at the start and now your score has reduced or improved and probably our treatment is working. So if the alopecia areata predictive score is 2, there are 98% chances of hair regrowth on the current therapy which you put the patient on. If the score is 1, there are 89% chances. If the score is 0, only 13% chances of hair regrowth are there on your current treatment. -1 says there are only 2% chances of current therapy. -2, -3, -4, obviously less than 1%. So you probably have to change your treatment if you belong to these red tiles: 0, -1, -2, -3, -4. So this is one of the objective ways of documenting. So the remitting phase of alopecia areata, where the hair growth has already begun on your treatment, you get to see these regrowing hair. Regrowing hair are small upright hair that are not thicker distally. Lone exclamation mark here. The lone exclamation mark here marked over here with the black arrow, and then vellus hair admixed with the terminal hair. These are the features of remission phase of alopecia areata on treatment. Okay, so we've talked about 2 major diseases on trichoscopy, their features on trichoscopy. One was androgenic alopecia and another one was alopecia areata. Now let's start with the trichoscopic features of trichotillomania. Very, very, very confusing and tricky sort of hair fall. Most of the times, patient and the attendants are not willing to accept the diagnosis, and we have to spend really hours and hours making the patient understand the nature of the disease, the nature of the problem, and probably the type of the treatment that we offer the patient. Patient is not able to understand, not willing to accept, and it really puts us under pressure. This is going to be the chapter 3 of dermatoscopy. And in chapter 3, as I promised earlier, we'll be discussing about the chaos and clues method. This is one of the dermoscopic methods in diagnosing skin lesions. And so, similarly, a patch of hair loss, not always alopecia areata, but you suspect because it was accessible area on the scalp, and probably the history is pointing towards the diagnosis. So you think maybe this is alopecia areata, or it might be trichotillomania. Some bizarre sort of patches are already there in rest of the scalp, so the diagnosis becomes difficult. You use your trichoscopy and then you see these broken hair. In trichotillomania, since there is compulsive desire of patient to pull the hair, and then obviously because of that pulling force, the hair tend to break at different levels. They might get broken at the root of the hair closer to the scalp, or they might get broken at different levels. So you see the broken hair, as you can see on the left hand side, the hair are broken. There is dispersion of the hair fibers, as you can see over here, the fuzzy picture. And then over here as well, the hair fibers are dispersed. The hair is broken. It's not in single unit. There is dispersion of the hair fibers distally, and the proximal is a single unit. Okay. So coiled hair, so in the process of pulling the hair shaft becomes thinner and thinner and thinner till finally it ruptures. And then the proximal leftover part coils around itself. It's a coiled hair. So the coiled hair is a diagnostic feature of trichotillomania. There are a few more features of trichotillomania. For example, the flame hair. Flame hair is just like a flame where the proximal end of the shaft, which is close to the scalp, is thicker. And then distally, you see these ash-like things, the dispersed distal part of the hair follicle appears like a flame. So this is the flame hair. Okay. The V sign. V sign is when the two hair are broken. The two hair were actually coming out from the same hair follicle, and then two of them get broken closer to the scalp. This gives you a V sign. So V sign is also diagnostic for trichotillomania. Then tulip hair. Tulip hair is something, the distal part of the hair is darker as compared to the proximal part. It seems a little bit thicker as well. So this is in the shape of the tulip, where you can see a small breach in the middle of the hair shaft and the two corners on the both sides. This is something to see with real effort. If you can, see the middle notch and the corners are a little bit longer than in the middle of the shaft. So this gives the false impression of a tulip. Maybe I'll show you the tulip shortly. And this is the hair powder. Once whole of the hair has been pulled out, the leftover parts of the hair are broken. Some of them are there within the skin of the scalp, while some of they are dispersed outside the scalp. And this we call the hair powder. These are the broken parts of the hair, which are in the form of concretions, maybe. All right. So this is the simulation with the tulip. So tulip hair, as you can see, the distal part of the hair is a little bit thicker and darker. Don't mix it up with the exclamation mark here of alopecia areata. That was totally different. So this is darker and in a little bit rounded, and the thickness of the distal part is only in the limited hair shaft. And then you see this normal thickenings of the hair shaft. Rest of the hair shaft is of thinner, thickness. Thinner shaft is there in the proximal area, a little bit thicker but globular with rounded edges distally, and the color is also darker. So this is the definition of the tulip hair. Okay, so we have discussed three diseases trichoscopically, and now is the turn for tinea capitis.
मेरी जो एप्लीकेशन है इसका नाम है स्किन चेक प्रो, और जैसे कि मैं आपको अब ये दिखा रही हूँ कि हाउ डज़ इट वर्क। बेसिकली व्हेन यू ओपन इट अप तो यहाँ पे राइट साइड पे आप देख रहे हैं ब्राउज फाइल्स की ऑप्शन है. वंस यू ब्राउज फाइल्स तो आपके सिस्टम में या फ़ोन में मौजूद पिक्चर्स यू कैन पुट देम अप इनटू दिस ऐप एंड विद इन अ फ्रैक्शन ऑफ अ सेकेंड दिस कम्स अप विद अ प्रॉपर diagnosis. As you can see on the left hand side, it has diagnosed the skin lesion as melanocytic nevi with 68% probability. And
So this was the patient who came to me and the mother was like, डॉक्टर साहब ये पैच बन गया है पिछले 1 महीने से एंड इट्स ये वाइट है और ये थोड़ा पाउडरी पाउडरी सा है. सो द डिफरेंशियल्स ऑब्वियसली वर सेबरिक डर्मेटाइटिस और टीनिया. तो उसके बाद जब हमने ट्राइकोस्कोपी की तो हम हैरान रह गए कि ट्राइकोस्कोपी के ऊपर हमें नजर आया ये. सो ये क्या था? दिस वाज एन एक्टोथ्रिक्स टाइप ऑफ tinea capitis. The spores have particularly surrounded. They have surrounded the hair shaft from all the sides to give it a false appearance of whitish. White hair. See this hair. The caliber of the hair is thinner, but because of this sleeve-like sheet of ectospores all around the shaft of the hair, it seems as if something is wrapping up this hair. So this was an ectothrix type of hair, tinea capitis. Okay. So another feature, corkscrew hair. Corkscrew, as you can see in this picture, corkscrew hair are also diagnostic for tinea capitis. Because of the destruction of the hair shaft, because of the presence of fungus over there, it is coiled like a corkscrew. So corkscrew hair is diagnostic for tinea capitis. Okay, so this picture shows many features of tinea capitis. For example, the light blue arrow is showing you bent hair. The hair is bent over here because of that weakness in the hair shaft, because it is being destroyed by the fungal spores. And then block hair. The thickness of the hair is the same, but a small stud-like hair is visible. It is obviously broken. And the thickness is the same distally as well as proximally. It's darker. So it's called the block hair, shown by the purple arrow. And then broken hair, dark blue arrow, the broken hair over here. And then obviously Morse code hair. Morse coding means that throughout the length of the hair, there are different points where the hair appears depigmented, just like coding, Morse coding of something. So this is called the Morse code hair, and this is because of the presence of fungal spores and destruction of the hair. The normal color of the hair is not visible at the points of destruction, and this is somehow similar to the picture that I showed over here. The parts of the hair encircled by the spores give you white appearance, as you can see over here, 2 places. So this is similar to Morse code hair. Okay. And obviously, the yellow arrow is showing black dots where the hair has actually fallen off from the scalp. So you can see black dots are visible not only in the trichoscopy of tinea capitis, they were also visible in trichotillomania. They were also visible in alopecia areata. But in a trichoscopic picture, if you get to see majority of the black dots, this was diagnostic for alopecia areata. So many features can be found in many diseases, but then this is the priority of diagnostic features. For example, some of the features might be hallmark for some diseases, as exclamation mark is a hallmark for alopecia areata diagnosis. And black dots, if you can see, majority of the trichoscopic picture is giving you black dots. Majority of the hair have fallen off, like as giving you the appearance of black dots. So this would be diagnostic for alopecia areata. But if you see only 1 or 2 black dots, but rest of the feature are in favor of some other disorder, so probably you can, make up your diagnosis like that. Okay. So another hair problem is telogen effluvium. Telogen might be because of many reasons. I'm not going to go into the details, but it appears like this. Sometimes telogen hair loss is pretty much easier to be diagnosed on clinical history and examination, but sometimes it's not. So when the case is kind of confusing one, you don't know whether it is hair loss because of nutritional deficiency, hair loss because of female pattern hair loss, or it's a diffuse case of alopecia areata. Then you put your scope on, and then you get to diagnose this case, which is a telogen effluvium. So in telogen effluvium, there is diffuse thinning of the hair, and on trichoscopy, you see that the caliber of the hair is the same. There is no heterogeneity in the hair shaft. The caliber is the same, the color is the same. So there is no diagnostic feature of alopecia areata. Black dots are not there. So this is the diagnostic picture for telogen effluvium. So hair thinning is there in telogen, but you have a a similar caliber. There is monotony in the caliber of the hair. But in androgenic alopecia, obviously, if you remember, if you do not remember, let me memorize it to you. That these are smaller caliber hair and these are the thicker caliber hair. So you see very thin caliber, intermediate caliber, and thicker caliber all in one case of androgenic alopecia. So that's what we call heterogeneity in the hair shaft. And there is no heterogeneity in telogen effluvium. All the shafts are of similar thickness. So let's touch some of the hair shaft disorders, or maybe one or two. This is trichorexis nodosa. Till now, So, my dear fellows, I'm obviously I have a YouTube channel from which I'm talking to you right now. So I usually make videos on skincare, and they are meant for the public awareness because they are in the local language. And probably this is the only channel in Pakistan that is taking care of all the skin matters in the local language, easily understandable language for the public to know. So you can follow me there on this channel, and you can help me make useful videos for the public if I have just missed out anyone. And I do have a Facebook page as well. You can follow me over there. Thank you so very much for bearing with me for this time and listening to my presentation. If you have any questions regarding face washes, you can just let me know in the comment section, and then I'll be replying you over there as well. Thank you so much. We have discussed the hair follicle disorders, that is androgenic alopecia, alopecia areata, trichotillomania, telogen effluvium, tinea capitis, but this is hair shaft disorder, which is trichorexis nodosa, and we see many cases of trichorexis nodosa in our clinical practice that have used heating devices, the hair grooming procedures that the patients undergo lead to breakage of the hair at different levels. This is the breakage of the hair because of traumatic procedures. So this is called trichorexis nodosa, the nodular thickening of the hair somewhere leading to fracture of the hair. This is diagnostic of trichorexis nodosa. All right. So some more examples, real life scenarios, my own patients of trichoscopy. And how about having a pause over here and just, start up with another presentation sometime later. You can have a pause over here, and then you can revise. You can go through that presentation which I just delivered another time, revise your concepts, and then the coming up examples. The next part of the presentation is going to be some examples, and I have not labeled those cases. So these are for you to come up with. Okay. So this is your own, this is your own diagnostic working of your mind, how you go about those images. This is for your own practice. But anyhow,